All right, so it says that PFT is an advanced test used to measure how effectively the lungs are working. Okay? People don't just come into the hospital and have PFT done. Okay? For you to have a PFT test done, they might have detected something inside your lungs. Something is going wrong. So it is a special test. Okay, so it's not like drawing blood from somebody who you may think has infection. Now, for instance, there is a lab test that we call the CBC, complete blood count, which measures your hemoglobin, your hematocrit, your white blood cells. Just about anybody that comes to the hospital will have that lab done. So that's different. This is a special test, okay? To make diagnosis of pulmonary disease, okay? Mostly performed by respiratory therapists. So once you graduate and you decide to become a pulmonary function technician, you can do it with your RRT credential. But now, if you want to get more advanced in doing it, especially if you want to work in a diagnostic lab, then you can go further and get your registry in PFT, okay? Registered Pulmonary Function Technician. You don't need any more schooling to do that. All you need is to take that test after you have passed your RRT exam, and then you get your RPFT. Usually they will pay you a little more, okay? They'll pay you a little more. PFT can be performed at the hospital, doctor's offices. You can work for a doctor, and what you just do there is to do a PFT. I don't know if you are rotated to a doctor, what's his name? Medical director, Dr. Duff. Did you all go to Dr. Duff's office? Okay, so we used to send students there to go and do, yeah, you did your PFT in Hispaniola, right?
Yes.
Yeah, okay, yeah. So yeah, you can work for a doctor doing your PFT there, okay, or maybe outpatient clinics. What's wrong with this? Okay. All right, so indications for pulmonary function tests. Diagnose the presence or absence of a lung disease. You're having shortness of breath. Okay, and the doctor wants to know why. And the doctor can recommend that you go have PFT done. Quantify the extent of lung impairment caused by a disease process. Okay? How much damage has the disease process caused? How do you feel now? How is your breathing? Okay, is it very severe or is it not very severe? So we can determine that by doing PFT, because once you have a pulmonary disease, okay, your pulmonary function will begin to deteriorate. Okay, you may not be able to exhale out like you used to. You may not be able to breathe in like you used to. Okay, so we want to find out the extent of damage. Measure the effects of occupational or environmental exposure. Now, some people may be working at a place that they inhale a lot of dust or silicon, okay? And then that affects their the function of their pulmonary system, okay? Like when I was younger, I used to work in this place that they made batteries for cars, okay? Because of the lead, okay? We wore the respirators, you know? And then the protocol was every 2 months you get tested for the amount of lead in your blood. because you can inhale it. Okay? So we can do that. If you're working in those kind of places, every once in a while they can, test you to see whether your pulmonary function is still okay. All right? Determine beneficial or negative effects of a therapy. That is true. Okay? Like patients that have asthma. Okay? There's something called pre and post bronchodilator therapy. If a patient has asthma and we want to determine whether that patient, the bronchodilator will help that patient if they're taking it on a continuous basis, we can bring them to the pulmonary lab, have them blow into the spirometer, we measure the amount of flow coming out from their lungs, and then we give them a breathing treatment with albuterol, and then have them blow back into the spirometer to see if they have more flow coming out from their lungs. So if they do have more flow coming out from their lungs after they have had the bronchodilator, that means that they can benefit from using it. Okay, so we can do PFT for that. Assess risks for surgical procedures. Yeah, if you're going to surgery, the doctor wants to test and see how your breathing is going to be when you come back. Okay? In fact, you are assessing the conditioning of your lungs. Okay? Would you do okay with the surgery? So we can check your lungs before you go to surgery. Evaluate pulmonary disability or impairment. And that is correct. This is for Social Security. Okay, like somebody, for some reason, can't breathe very well, and as a result of that, they can't get employed, they can't work anywhere. Well, you have to prove to the Social Security Administration that, because of your pulmonary problem, you cannot work anywhere. Okay, so we can do PFT and show them that the values are abnormal so that they can go ahead and start paying you. Okay? That's the one I need to do, really. I need to do that test so I can retire before I get 65. How about that? And then when you do these type of patients, you can see that they try to fake the test. You bring them to the lab and you go, blow hard, and they go, like that. Suck in really hard. So they're faking the test so that they can fail it, so that they can be qualified for Social Security. Okay? All right. Every PFT equipment must comply to the standards set by the ATS and the European Respiratory Society. Now, ATS is American Thoracic Society, and then ERS is European Respiratory Society. These two agencies are responsible for approving, okay, any PFT equipment that is going to be used on somebody. So if you're using an equipment that is not approved by any of these two agencies, we may not validate the result that you're getting from the agency. Okay? We may not validate the result. Like if you used another equipment that is not approved by them, and you tell me, well, somebody's starter volume is 500. Well, I can't validate that because I don't trust that equipment that you used. Okay? Every spirometer must be calibrated daily before use. Now, a spirometer is a device that measures volume. That is the stuff that we blow into. Anytime you blow into a spirometer, something moves. Okay, and that is called volume displacement. Volume displacement. So a spirometer measures volume when you blow into it. So every day, if you are a pulmonary function technician, you come to work, the first thing you do is to calibrate your spirometer. And we use what we call a super syringe to do that. We're going to talk more about that. Flow measuring devices must be calibrated to ensure accurate measurement of PFT value here. So you're going to be blowing into the device, You want to make sure that the equipment that measures the flow that is coming out from your lungs, is calibrated too. So you calibrate that. We have gas analyzers when we do PFT. Like now, if I breathe in 100% oxygen and blow it into the device, I have to have something there to measure the concentration of oxygen in it. If you're doing a test that involves using nitrogen, you have to have nitrogen analyzer in the device. If you're doing the test that requires like diffusion capacity, we always measure the concentration of carbon monoxide and nitrogen as well. Okay? So we have different analyzers that are in the equipment that we use inside this parameter. Okay? Any questions about that? So these are equipment that you can find in a typical pulmonary function lab. They may have more, they may have less, but typically you find these ones here. This parameter, like I said, measures volume. If we want to measure a patient's lung volumes, we use parameter. Pneumotachometer is a device that measures flow. Okay, now, do you know what the peak flow is? Like the peak flow that we give to patients that have asthma, they blow into to see if their airway is still open. Yeah, any device that measures flow is called a pneumotachometer. Now we have the Rice respirometer. You probably saw the Rice when you did the winning parameters, right? The Rice, did you go over there? Okay, so you blow into it, it's measuring flow, but it's displaying volume, okay, because volume times time, flow times time is volume, okay? So the Rice respirometer is a pneumotachometer. It measures flow, okay? And then we have diffusion systems. That will be the device that we use to measure how well gases can diffuse into your lungs. DLCO, we're going to talk about that. If you want to measure how well gases can diffuse into your lungs, then we do a diffusion system. For instance, when you breathe in oxygen, okay? And then you exhale carbon dioxide. That's called ventilation, the movement of gas into and out of the lungs. But now, once you breathe in and get that air inside your lungs, you can't just go to sleep. You wait, because you got to get that oxygen inside the blood. Okay? So the way that the oxygen enters the blood is through the process of diffusion. If the oxygen cannot diffuse into your blood, then you're going to have hypoxemia. So sometimes in the pulmonary function lab, we want to test and see if a patient breathes in, is the oxygen going into their lungs, into their blood, and the carbon dioxide coming out from their blood. Okay? We're going to have gas analyzers. We have oxygen analyzer, nitrogen analyzer, helium analyzer. There's a test called the helium dilution test. Okay, so we have those analyzers to measure the concentration of whatever gas that we're dealing with. We have nebulizer. If we want to do a pre and post bronchodilator therapy, we're going to have a nebulizer that we're going to use to administer the albuterol. Sometimes you may have to do ABG, but that's very rare. It's really very rare that you do ABG in the pulmonary function lab, but that is possible. Okay? And then we have treadmills. Okay? Treadmills. All right, so this parameter, like I said, is volume collecting or displacement device. If you blow into it, something moves. Okay? And then you measure your volume. Patient breathes in and exhales into this parameter for volume measurement. This parameter is calibrated daily before use. 3-liter super syringe is used to calibrate this parameter. Now, that's super syringe, we got a few of them in there in the lab. The capacity is 3 liters, okay? So every morning, we use that syringe, okay? And we'll pull it all the way back, and then we'll push it into this parameter. Now, calibration means that you are taking a known value and you are putting it into something, and then you are expecting that thing to read out what you put in there. Like I know that this is 3 liters. So if I'm calibrating my spirometer, I'm gonna plunge it in, and I want that spirometer to read that I put in 3 liters. If it does that, then it's in calibration. If it doesn't read back 3 liters, then it's not in calibration. We have to somehow tweak it until it reads 3 liters, and then we can start using it. Okay? If the spirometer doesn't come in when you're trying to calibrate, you can use it. We cannot validate the results that you're getting from your PFT test. Okay? And then Charles's law, that's God's law. I know what you're saying. Oh my God, not again. Well, now, Charles's law is stating that if volume is constant, when temperature increases, no, so let me say that, I said it wrong. Pressure is constant, okay? When temperature increases, volume increases. That's what Charles' law is saying. If pressure is constant, when temperature increases, volume increases. So anytime we do PFT, the equipment that we're using, okay, is in ATPS, ambient temperature pressure saturation. Ambient temperature, ambient temperature pressure saturation. So once we are done with the test, we have to convert it to BTPS, body temperature pressure saturation. And this is why, okay? Let's say that I'm going to do my PFT here inside this room, okay? What is the atmospheric pressure inside this room? Does anyone know?
760.
Yeah, let's say it's number 760. Well, Albuquerque is not 760, but let's say that it's 760, okay, in this room. My equipment is in this room at a pressure of 760. How about me, the technician standing here? The atmospheric pressure affecting me is also 750, right? 760. So it's constant with the equipment and myself. Okay. But assuming that the room temperature here is 90 degrees, what's my normal body temperature? 37, right? It's lower than the room temperature. Okay. Or maybe let's say that the room temperature here is 40 degrees, but my temperature is 90 degrees. I have temp, okay? I'm febrile, okay? So what's gonna happen then is, since the pressure is constant inside the room, and my body temperature is higher than the room temperature, when I blow into that device, the air coming out from me is very warm. Therefore, the volume will be falsely high. Are you getting it? Yeah, the volume will be falsely high because temperature has increased. Okay? So that's what we're doing here. So anytime we do PFT, we have to convert the values that we get to BTPS, the patient's body temperature, okay, to make sure that the numbers are right, okay? So now you don't have to worry about how to do that, but they have what they call the BTPS factor, okay? And the computer does that for you. The computer will multiply it out, okay? This is what the patient did, and then BTPS is this, okay? Based on the patient's body temperature. Any questions about that?
So the machine will detect what body temperature is?
Say it again?
Does the machine actually detect what
Yes.
body temperature is?
Yes, yes, yeah. All right, so now we'll go to a pneumotachometers, a device that measures flow. They are also called, they're also used in the ventilators to continuously measure flow and volume. So because of the pneumotachometers that we're able to get the readout of the tidal volume and the flow and the ventilator. So we have them inside the ventilator. Okay? We have what we call the differential pressure pneumotachometer, the flash pneumotac. Okay? We have right respirometer. That's a pneumotachometer because it measures flow. We have heated wire flow sensor type of pneumotachometer. And then we have peak flow meters. Peak flow meter is also a pneumotachometer. Okay, so here is differential pressure pneumotachometer. Okay? This is it right here. And what you see here is inside here, the mouth is here, somewhere here. Okay? All right, so it says that flow is measured as air passes through a flow-resistive device, and the difference in pressures determines the flow rate. So once you blow in, this is the resistor, okay? Now, the pressure goes up, okay? Then you get more, that will mean more flow, because remember now, if you think about mechanical ventilation, if you increase your flow, your pressure goes up, okay? Your pressure goes up. You use flow to build volume, and then you use volume to build pressure, okay? So if your volume goes up, your pressure goes up, okay? Well, if the pressure doesn't go up as much, then that means that your flow is low. So basically, that's the way this one here works, okay? Measurement is more accurate when flow is laminar, meaning that it's going very slowly, okay? It can measure minute ventilation continuously, okay? It is inaccurate at low or high flow, okay? Just know that the differential pressure pneumotachometer is out there. It is a type of pneumotachometer. That should be enough. Okay? Now, if you are a PFT technician and you get ready to do PFT, you don't need to explain that to your patient. Well, excuse me, sir, I'm going to be using a differential pressure pneumotachometer today. They say, what? What are you talking about? So they don't need to know that. Okay? All right, so here's the right respirometer. I know you all have seen that. It's a pneumotachometer because it measures flow. Okay? You breathe in and then you blow into it. Okay? We have two veins here, or what they call the turbine. The long one and the short one. Okay? And the short one reads, and this one here, the short one reads the milliliter. And the long one reads the liters. So when you blow into it, if the short one circles around one full circle, that's 1,000 milliliter. Well, there is 1,000 milliliter in 1 liter. So the big one will move to 1. Okay? If you blow into it and the small one makes 2 full cycles, that's 2 liters. And the big one will move to 2. So that's the way it works. Okay? Blow into it, it makes 3 cycles. That's 3 liters, but now if the small one is, let's say on 10 here, that would mean 3.10 liters. Okay? So that's the way you read it. Okay? Now, we can use the Rice respirometer to measure slow vital capacity. Okay? Now, slow vital capacity is where you are going to instruct your patient to take a deep breath, but blow it out gradually but completely. That's different from forced vital capacity. When you go to a PFT lab, what the patients do is forced vital capacity. Take a deep breath, blow out, keep on blowing, keep on blowing, keep on blowing. I mean, if they're pretty old, they may die for you, from you, yelling at them like that. Okay? So I just want you to know that if we're going to estimate our patient, we need to do slow vital capacity. Because the slow vital capacity is used to measure the strength of the respiratory muscles. Okay? You want to make sure that your patient is strong enough so that once you estimate them, they can sustain spontaneous ventilation and oxygenation. Okay? So that's why we say that it is accurate between 3 to 300 liters per minute. Okay, if you do a forced exhalation through the device, it can break these veins here. Okay, it can damage the device. So we don't use it for forced vital capacity. Because on the test, they may go, which of the following would you use to perform forced vital capacity? Well, you don't want to pick Rice respirometer. What we use it for is slow vital capacity, bedside vital capacity. Okay? If you need to do forced vital capacity, then you need a spirometer. Okay? A spirometer. Okay? Any questions about Rice respirometer? It is a pneumothopometer. Okay. If I put my mouth on that in there and breathe for 1 minute, measure the volume for 1 minute, that's my mini volume. Okay? If I just take 1 breath and exhale in it, that's my tidal volume, because tidal volume is the amount of volume that you exhale out in 1 breath. Okay, so we can use it for tidal volume, we can use it for vital capacity, slow vital capacity, we can use it for mini volume. Okay. Well, if I measure my tidal volume and measure my mini volume, guess what? I can calculate my respiratory rate. How many times that I blew into that device. Okay? All right. Let's review a little bit here. But before that, let me drink some water. Anytime my mouth dries up, I begin to speak Nigeria. I don't know if you have noticed that. All right, so name 2 indications for pulmonary function testing. Anybody? Why would we want to do a test, pulmonary function test on somebody?
See if someone has COPD.
Yeah, I want to see if they have COPD, correct. Anything else? Disability, right?
If working or not working.
Mm-hmm. Yeah, a bunch of reasons there. We want to measure the extent of damage done to the lungs as a result of the pulmonary disease. What is a spirometer? Spirometer. A device that measures volume. A device that measures volume is a spirometer.
Dr. O,
Yeah.
on our homework, one of the questions is, what percentage should calibration come in when calibrating his parameter? I don't remember.
Okay, yeah, we're gonna get to that when we do, but it's 3.5%. Yeah, 3.5%, but we'll get to that. All right, so a pneumotachometer is a device that measures flow. Okay, because on the body exam they can say, which of the following is not a pneumotachometer? And then you go, pneumotachometer, what in the world is that? But what they're talking about is like peak flow, rise respirometer, differential pneumotachometer. Okay, so you pick one that is not one of those. Okay? Why is it necessary to convert measured lung volumes from ATPS to BTPS? For accuracy. Because if there is temperature difference, if the patient body temp is higher than the room temperature or lower than the room temperature, that can give us a false result of the patient's volume. Okay, so we want to convert it to the patient's body temperature. Okay? What device is used to calibrate a spirometer? That super syringe, that long syringe. Don't let anybody give you an injection with that. That'd be too much, right, bro? That stuff scares me. You'll give me medication in 3 liters. Well, I may probably die right away. All right. Okay, so here is the heated wire flow sensor. Okay? It is a pneumotachometer because we use it to measure flow. Now, right here you have the heated device here. It's warm. Okay? So what happens is that when the patient sucks in, the quicker the temperature of this drops, would mean that you have a lot of flow to cool it down. And then if you blow in there, if you suck in and it doesn't go down, the temperature doesn't drop very fast, well, you didn't have enough flow to cool it down. So that's how this one here works. All of these here will be in that little handheld mouthpiece. So you may have differential pneumotachometer. You may have this one there, okay, to measure your flow. So the higher your flow, the quicker the whole device gets cooled down. Okay? The lower your flow, the longer it takes for it to cool down. That's where it measures flow. Okay? Accuracy, accuracy of measured value is greatly affected by humidity and temperature of the gas. Okay? Now, if the gas is already very warm and you blow into it, the temperature will rise higher. Okay, meaning that actually that you have a lower flow, you know. So we have to make sure that the temperature is not affecting the device. Okay? You are two at room temperature. All right, you ready, Tom?
Yes.
Okay. All right, so
I think Love was. I
this
think she said
is
Miss Kathy.
peak flow meter. It is a pneumotachometer because it measures flow. That is the stuff that we would normally give to somebody that has asthma to monitor themselves. You know, like you tell them when they're having shortness of breath, they need to blow into the device, and then usually we have like a green zone, yellow zone, and a red zone. So if they blow into the device, and this little lever here moves to the green zone, it means that their airway is still patent. That's good. But if they blew into the device and the thing went to to the red zone, then that would mean that they need to go to the hospital right now, that their airway is closing up. Okay, so it's actually measuring flow. So it says that it measures peak expiratory flow at the bedside. Okay. Patient exhales forcefully through a device that incorporates a resistor and a movable indicator, which is this here. Okay? And then it says accuracy is affected by patient effort. Okay, the patient really want to do it, take a deep breath and blast the flow through it. Okay? Now, moisture and debris can affect accuracy, or maybe if the patient coughs when they're trying to do it, the force of the cough can move the thin way up to the good area, and then that will be false results. Okay? But usually, a respiratory therapist will educate the patient on how to use a peak flow meter. Okay? If they come into the hospital and they're doing well, you have them stabilized, and they're going to go home, they have asthma, it would be a good idea to give them a peak flow meter so that they can use it and monitor their breathing. Any questions about that? Now this is a plethysmograph, okay? I will call it the body box. We have one of those in there in the lab. What we use it for is to measure the functional residual capacity. Functional residual capacity. Now, the functional residual capacity is the amount of air that is left inside the lungs at the end of normal exhalation. Let me say that again. Functional residual capacity is the amount of air left in the lungs at the end of normal exhalation. So anytime you exhale like normally, you have two volumes left. You have your ERV, we're going to go over those. ERV, respiratory is that volume, plus you have your residual volume that you will never exhale out from your lungs, regardless how hard that you try. Okay. Now, spirometer cannot measure functional residual capacity. We cannot use a spirometer to measure functional residual capacity. If you want to measure a patient's functional residual capacity, you're going to have to use the body box. Okay. Or maybe you can do another test that is called the helium dilution test. Or maybe you can do another test that is called the nitrogen washout test. So those three tests are used to measure the functional residual capacity. So, one thing that I really want to emphasize about this right now, because we're going to cover it down the line, is that the entire patient is encased in there. You can see that the patient is in there. Okay, so when you're doing the test, regardless of where the air may be in their body, it's going to measure it. It has the capability of measuring trapped air. Okay? So that's one thing good about this. Now, if a patient has COPD and they want to measure their functional residual capacity, okay? Let's say first I measure with the nitrogen washout test, and then let's say that like 20, and then I turn around and measure with helium dilution test, which is another test that you can use to measure the functional residual capacity. I'll also do 20. But if I measure with the body box, I get a higher number, 50. What's the reason for that? It's because the helium dilution test and the nitrogen washout test cannot measure trapped air. But the body box can, because the entire patient is encased. So it's one of the questions that you may get on your body exam, that the patient had their functional residual capacity measured with helium dilution test or nitrogen washout test, and then they turned around and had it measured with the body box. There is a difference. How can you account for the difference in the results? It would mean that that patient is air trapping. Okay? All right, so other things, the thing works by Boyle's law. Another guy's law. And the Boyle's law states that if you hold temperature constant, if you're holding temperature constant, the volume the gas will vary inversely with the pressure of the gas. If you hold the temperature constant, the volume of the gas will vary inversely with pressure. In other words, if the volume is going up, pressure is going down. If volume is going down, pressure is going up. So that is the principle through which this body box works. We're going to talk more about that when we cover that. Okay? We can also use the body box to measure airway resistance in patients that have COPD. It measures airway resistance, and then it has the ability to measure the entire volume inside the patient's thorax. That's called the thoracic lung capacity. Okay? We can measure the entire volume. The body box can do that.
I'm
Okay.
sorry.
That's okay. So let me say one thing too. So now I want you to know that the body box can measure thoracic lung volume, the entire volume. It can measure airway resistance, and then you can measure functional residual capacity. Okay, so on the exam, they may say, which of the following will you not measure with the body box? Okay? All right, tell you, it's all yes. So it's able to measure flow. Okay, so every day that we want to use the body box, we have to calibrate the chamber for pressure, and then we'll calibrate the pneumotachometer to make sure that it's going to measure the flow very well. So in this box here, the patient is usually instructed to breathe normally, and then after a while they are told to pant. And then they go, have you ever watched this? Do you all see this when you do your PFT? They have a very small PFT lab, you know. So they instruct the patient to breathe normally, and then as they're doing that, then the technician tells them to pant, and then they take a little break. Okay, so at that time, the device will measure the pressure inside the chamber, and then the pressure inside the patient's chest, and then relate it to volume. Okay? That's the way that we measure the functional residual capacity. Okay, so it says that one of the advantages of the box is that it is more accurate in measuring functional residual capacity. I want you to remember that question on your body exam, okay, where a patient had their functional residual capacity measured by nitrogen washout or healing dilution, but when they had it measured with the body box, it's a different result. Why is that? That is because the body box is able to measure trapped air. It's going to measure air, no matter where it is in your body. Okay? So that's what we're talking about. All right? Disadvantages. Physical limitation may prevent patients from entering the box. Claustrophobia prohibits patient from entering the box. Patient may not be able to perform acceptable pants. Like when you tell them to pant, to take tiny breaths, they may not be able to do it. Okay? So those are some of the disadvantages of the box. Let's go to break about 2:30. So I can do a little more. Okay, so now we're back to that super syringe. Okay? Again, all equipment must meet the standards set by the American Thoracic Society or the European Respiratory Society if we're going to validate the result that you're getting from the test. We know that you're using the right equipment to do that PFT test. Okay? Volume calibration and leak test are done by using a large volume syringe. Which of the following equipment will you use to calibrate a spirometer? Then you're going to say a super syringe. That's a common question on the test. See how easy it is? The body exam is very easy. You know, they know you have to pay them, so they make it easier for you. All right, so normal volume of the super syringe is 3 liters. That's what it contains. When you pull it all the way back, you got 3 liters, okay? And then you're gonna plunge it into this parameter. Well, the caveat about that is that sometimes once you push it in, you may not get 3, okay? Meaning that it's not in full calibration. But if that is the case, well, we don't want to be doing that the entire day. Okay, what we have to do is to accept a result that is slightly high or slightly low. Okay? So is 3.5% of 3. Okay, so now it goes like this. Here's the 3-liter syringe. Okay, I want it to be 3, but it can't always be 3. Okay, it can't always be 3. So now 3.5% of 3 is like 0.105. So if I plunge in the 3 liters and I have 3.105 from here to here, that will be fine. It doesn't have to be perfectly 3. If it is 2.985, meaning that 3 minus this number will give you this, that will be fine. So this is the acceptable range, 3.5%. Okay? So on the exam, they may say, well, you are trying to calibrate this parameter and you're getting a number now that is way greater than this. 4, 5, whatever, greater than this number. What may be causing that? You have some kind of obstruction in the system. And you cannot use it. You can't use it until you fix it. Well, it is less than 2.985. What may be causing that? Well, you have a leak in the system. It's leaking out. And you still cannot use it. Okay? So it has to come in within that range for you to use this parameter. Any questions about that? Flow calibration is done with a rotometer. It's like a flow meter. Okay? You run the flow through a flow meter, see how much it's going to measure. Well, if it measures right, well, it's measuring the accurate flow. Plethysmograph is calibrated by using a rotometer, but remember it's a pneumatachometer, so it's measuring flow. So we're going to calibrate that and then turn around and use a barometer is used to calibrate any pressure equipment. So because the device is also measuring pressure, we want to make sure that the pressure that is being measured will be accurate. So we'll calibrate it for pressure, and then we'll calibrate it for flow before we can use the body box. Okay? Timing devices are checked with stopwatch. Okay? Gas analyzer is calibrated to 0 by running a gas through it that is free of the gas that the analyzer is designed to measure. Okay, now, let's say that this is oxygen analyzer, okay? And I let it out to room air. You know, this is the sensor, and then I'm doing this to room air. What percentage do you think is going to read? How much oxygen is in the room air?
21.
21%, right? Yeah, it's going to read 21%. Now, if I want to calibrate it to 100%, then that means that I'm going to get that sensor and put it in a bag, fill it up to like a flow meter, oxygen flow meter, and then turn my flow up. It's sensing 100% oxygen. Okay? So the way we calibrate oxygen flow meter is that, first of all, you're going to calibrate it to room air. You let the sensor out, and then it will drop to 21%, and then you calibrate it to 100%. It's 2-point calibration. You put it in a bag, one of those setup bags, turn your flow meter of oxygen on and fit it there, and then you let it sense 100% oxygen, and then it runs all the way to 100%, and then you get the analyzer out, and allow it to go down to 21% before you use it to measure your oxygen concentration. So oxygen analyzer, you must calibrate to room air first, calibrate to 100% oxygen, and then let it drop down to 21% before you use it. You may get that question on your body exam. Okay? Which two gases would you use to calibrate an oxygen analyzer? That would be room air and 100%. Okay, so now, I know that there is 21% oxygen in room air, but if I want my oxygen analyzer to read 0 on room air, what would I have to do? Because if I let it out like this, it's going to read 21%. So, but if I want it to read 0, if I want to calibrate it to 0, what I can do then is to flush any gas that doesn't have oxygen in it. Like I can flush nitrogen through it, and it will read 0 then. I can flush nitric oxide in it, it will read 0. Or any gas that doesn't have oxygen in it. Okay, how about nitrogen analyzer? If I calibrate that to room air, what would it read? Nitrogen analyzer, how much nitrogen is in room air? Approximately 79%. Actually, we have more nitrogen in room air than we have oxygen. That's kind of funny. Anytime you breathe in, you're actually breathing in more nitrogen than they are breathing in oxygen. Okay? But the thing though is that the nitrogen that we breathe in doesn't go into the blood. There's no diffusion gradient. The amount of nitrogen inside the blood or inside the body is proportional to the nitrogen inside your lungs. So there's no diffusion gradient there. So, but the nitrogen stays inside the lungs. That volume of nitrogen that you're breathing in, all it does is to help keep your lungs open. Okay? So that's why when we're doing that functional residual capacity, the amount of volume left inside your lungs at the end of normal exhalation, we want to extract the nitrogen. We have you breathing 100% oxygen so that we can deplete the volume of nitrogen. And then we measure the amount of volume left. Okay? So, if I calibrate a nitrogen analyzer, remember, it's going to read, to be accurate, 78.9%. That's what it is, approximately 79%. But now, if I want to calibrate it to room air, no, excuse me, if I want to calibrate it to 0, how would I do that? I can flush any gas that doesn't have nitrogen in it. I can flush oxygen through it. And it will read 0 because it's no longer sensing nitrogen, right? So if you want to calibrate an analyzer to 0, okay, you flush that analyzer with any gas that doesn't have what that analyzer can measure. Okay? Any questions about that? Now, how about if I want to calibrate a nitrogen analyzer to 40% nitrogen? Well, all I have to do then is to expose the analyzer to 40% nitrogen. If I want it to read 40%, well, I get nitrogen that has 40% concentration and expose the analyzer to it. If I want to calibrate my oxygen analyzer to 50%, well, I'm going to expose it to gas that has 50% oxygen in it, and then it's going to reach 50%. Okay? All right. Oh, sorry. Now, so this is, we have two types of oxygen analyzers. Two types. We have the galvanic fuel cell analyzer. This is the same one that we have inside the ventilator that measures your FiO2. Okay? We have analyzer there. Once you turn that button, you say 40% or 50% or whatever. What you're doing is, the oxygen hose comes in from the back, the air hose comes in from the back, and both of them hook up to the ventilator. So once you turn that knob, you're closing off the air. Like if I want my FIU to be 100%, once I set it to 100%, I have closed, okay, what's the thing? The valve through which the air comes in. The air is blocked from coming into the ventilator. Okay, so you get 100% oxygen. If you set it to 40%, somehow you have closed it a little bit, so only a little amount of air will come in and mix with the 100% oxygen to dilute it down to 40%. That's the way it works. So once that happens, that air will go through the analyzer, it flows through it, and then you get your reading. Okay, so the analyzer said, yes, you set it to 40%, I'm actually getting 40%. Here it is right here. Okay, so we have it inside the ventilator. Okay? And then it says that it measures partial pressure but displays FiO2. Actually, this here measures the partial pressure of oxygen in the air, but it's displaying it as FiO2. Accuracy can be affected by water or and the sensor, high system pressures, and changes in altitude. Anytime you cannot calibrate the galvanic fuel cell analyzer, you change the fuel cell. Inside that you have the fuel cell. Okay? It doesn't use battery, it doesn't use electricity, nothing, just the fuel cell. So if you get it out, you're trying to analyze your FIT, it's not working, it's can't turn on, whatever, you change the fuel cell. Okay? All right, so we're done over that. And then the other one is polarographic oxygen analyzer. Okay? Similar to the galvanic fuel cell, except for the presence of battery. This one here uses a battery. Okay? It uses electrolytes. It's kind of like similar to clock electrode. Clock electrode measures the concentration of oxygen inside your blood gas analyzer. Like when you want to run your blood gas, there's a thing there called the clock electrode, which measures the amount of oxygen in the blood. Okay? But if this one here cannot calibrate well, it doesn't measure well, something's wrong with it, it can be either the battery or maybe the electrolyte level is low. Okay? Unlike the galvanic here.
Did you say it was the Clark electrode for the
Clark.
ABG?
Yeah, yeah. Clock electrode. So inside here, I don't know if you have analyzed ABG before. We have the sense electrode, and then we have the sobering house electrode, and then we have the clock electrode. So what happens is, if you drew a blood gas from a patient and wanted to analyze it, you go to the analyzer and you squirt it in there, okay? And then immediately the unit is going to hemolyze the blood, break it down, okay? And then the blood will begin to flow down the line inside the analyzer. It gets to the clock electrode. The clock electrode will measure the amount of oxygen in that blood. And then it flows down the line. It goes to the sobering house electrode. It will measure the CO2. The sobering house electrode measures the CO2 in the blood gas. And then it goes to the SANS electrode. The SANS electrode will measure the pH of the blood. So that's how you get your results. Okay? And then there is a pH reference electrode, which is called the calomel. That's more important. So, once the SANS electrode measures the pH, now this guy will measure it as well, so that when the blood comes down the line, it says, well, this is what I got as the pH of the blood. And then this guy says, yes, that's what I got too, okay? Before I press it out. And so all these electrodes are inside the blood gas analyzers.
And do we need to know those parts as well?
You just know that it's a reference electrode. It checks this guy out. Okay, it says, well, yeah, you got this, well, I got this too. Okay? If they don't correspond, you will bring it out as an error. Something is wrong, you have to rerun the blood gas. Okay? All right, so polarographic, if you're having problem with it, check your batteries, and then check and see if the electrolyte level is good enough, okay? But with the galvanic, if anything goes wrong with it, you change the fuel cell. It doesn't use battery, it doesn't use electrolyte, it doesn't use electricity, just the fuel cell. Any questions about that? We'll do this, we'll go on break. Well, I hope everybody knows what this is. Otherwise, you might as well go and do a medical assistant or something. But this is pulse oximeter. We use it to measure the concentration of oxygen attached to the hemoglobin. It does it by calculation. The pulse oximeter does not know what is attached to the hemoglobin. All it knows is that something is attached to it. Okay? So, it's based on, do I have it here written down? It's based on what they call the Lambert law. Hold on, let me write down. Is Lambert law. Now, this is not the beer that you drink. This is just somebody's name, okay? So don't go and tell them, well, Dr. O said that we can use the pulse oximeter and drink some beer. No, it's not that. Lambert beer law. Now, what this law here says is that hemoglobin has a natural tendency to absorb red light. Let me say that again. They're saying that hemoglobin has natural tendency to absorb red light. The more oxygen that is attached to the hemoglobin, the more red light that will be absorbed. The less oxygen that is attached to the hemoglobin, the less red light that is going to be absorbed. So now remember, in that pulse oximeter, it emits red light, right? You all know, right? It emits red light. Once you turn it on, you see the red light. So we have one side is the emitter, where the red light that sends the red light out, and at the bottom of it is a receiver. So we have receiver, and then we have the emitter. So it doesn't actually matter how you put it. The emitter can be on top or be on the bottom. It doesn't matter. So what's going on then is that once you put it on your patient's finger, the red light goes through the arterial bed, and the hemoglobin will absorb the red light. Whatever the red light that is not absorbed will come out to the receiver. Okay. So now, if I'm getting more red light on the receiver, that means that I have less oxygen attached to the hemoglobin. My oxygen saturation will be very low. But if I'm not getting a lot of red light coming out to the receiver, that means that the hemoglobin has a lot of oxygen in it, and my oxygen saturation will be high. So that's the way it works, okay, by the hemoglobin absorbing the red light, okay? It is a non-invasive monitor, okay? Now, like I said before, it does the calculation based on what is attached to the hemoglobin, but it doesn't know whether it's oxygen or not. So this is not the most accurate way of measuring oxygen concentration, okay? If somebody has carbon monoxide poisoning, because carbon monoxide diffuses 240 times quicker than oxygen. If I opened up a tank of carbon monoxide in this room now, and opened up a tank of oxygen in this room, everybody here will have shortness of breath. Because the carbon monoxide will quickly attach to your hemoglobin before the oxygen has had the time to do that. So it diffuses very fast. Okay? So now, if a patient has carbon monoxide poisoning and you measure the oxygen saturation with the pulse oximeter, it's going to read 100%. And the patient will still be complaining of shortness of breath. Okay? So we have three things here. We have SpO2, and then we have SaO2, and then we have the HbO2. That's three ways of expressing oxygen saturation. The first one stands for percutaneous oxygen saturation. You are using the pulse oximeter. You're measuring it through the skin. That's what it is. The second one is arterial oxygen saturation. Like you're running your blood gas analyzer, and then you get your O2 saturation. Okay? That one is also calculated. If you get somebody that has carbon monoxide poisoning and then you draw, you get a blood test from them and then you run it through the analyzer, it's going to read 100% as well. But now HbO2 stands for hemoglobin oxygen saturation. That's the most accurate. We use what we call the co-oximeter or hem oximeter to measure that. That can measure exactly what is attached to the hemoglobin. If it is oxygen, it's going to know it. If it is carbon monoxide, it's going to know it. If it is methemoglobin, it's going to know it. Okay, so that's the most accurate. This is most accurate oxygen saturation than these two here. These two here are calculated. This one here is measured. Okay, we use different wavelengths of light to measure what is actually attached to the hemoglobin. That's how come that we say that if you get a patient that is suspected of having carbon monoxide poisoning, you are better off running their blood gas with a co-oximeter or hem oximeter. Okay? Any questions about that? Factors affecting the efficiency of pulse oximeter. Yes, if your hands are cold, you will measure right. If your blood pressure is low, you will measure right. Overhead lights, okay, in the patient's room will cause you not to measure right. Patient activity, the patient is doing their finger like this, so when you're trying to measure it, you will measure right. If the patient has nail polish, if it is red, okay, and the red light shines through it, you will read it as hemoglobin that has a lot of oxygen in it, so your result will be falsely high. If you have brown or dark nail polish, then you will read it as deoxygenated hemoglobin. Your O2 saturation will be falsely low. If you have scar tissue in the finger on the finger that you're trying to measure from, it will not read right. So a lot of clinical factors will affect the efficiency of pulse oximeter. Any questions? All right, let's take a break now, and then we'll finish up.